Lego my strep pio. In this sketch, we'll work up streptococcal pharyngitis, the most common bacterial cause of pharyngitis in children and adolescents. Let's take a stop at the purple-striped Pâtisserie of Paris, world-renowned for its fresh strep pyogenes pies. Purulent filling. As always, pharyngitis is symbolized by the inflamed chef's neckerchief tied over the pharynx. As the name implies, strep pharyngitis is caused by infection with the bacteria Strep pyogenes, more commonly known as Group A strep, or GAS, hence the A in apple on the pyogenes pie. Fortunately, resistance to penicillin among GAS isolates has never been described. More on that later. In temperate climates, streptococcal pharyngitis is most commonly seen in the winter and early spring, depicted by the melting icicles on the window. Alright, without further ado, let's jump right into the presentation of streptococcal pharyngitis. Streptococcal pharyngitis classically affects school-age children, which is represented by the girl in a school uniform who is having a tantrum in front of the cake counter. It is so common that it is responsible for up to 30% of sore throats in this age group. That being said, streptococcal pharyngitis can still affect children younger than 3 if they are in close contact with school-age children. See the less than 3 heart symbol on the cake? But their presentation is atypical. Fortunately, children less than 3 are less likely to have complications of streptococcal pharyngitis, so identification in this age group is less important. Kids with streptococcal pharyngitis often present with a sore throat that comes on abruptly, depicted by the pain lines coming from our tantruming kid's mouth. They often also have fever and a headache, depicted by our overworked chef who is rubbing his head while his hat is on fire. They will often also have abdominal pain, which may include nausea and vomiting. You can see this represented by the sneaky kid behind the counter, who is clutching his stomach and green in the face. Because of these symptoms, these kids will often have poor oral intake, which is represented by the no outside food sign next to our queasy student. Lastly, be sure to ask about any viral symptoms, or lack thereof. This includes cough, coryza, conjunctivitis, anterior stomatitis, ulcerative lesions or vesicles, and diarrhea. Viruses are the most common cause of acute pharyngitis, and you will most likely not test a child for strep throat if they are exhibiting symptoms of any of these viral infections. We will cover tests after physical exam. We will also cover some of the viral infections to keep in mind in the differential diagnosis section, so stay tuned. In contrast, children under 3 with streptococcal pharyngitis may have a very nonspecific chief complaint of fever and clear nasal discharge. In the younger age group especially, you may only suspect strep pharyngitis based on exposure to an older sibling or daycare contact with a recent GAS infection, so be sure to ask about those close contacts. Okay, now that you've taken a relevant history, let's get to the physical exam. First off, palpation of the neck often reveals enlarged and tender anterior cervical lymph nodes, which are represented by the lines of nodular white dials on each side of the oven. Next, you'll want to have the kid open his mouth. In the posterior oropharynx, you can expect to see enlarged erythematous tonsils. If you take another look at our lower oven, you'll see that it resembles an erythematous oropharynx with 2 large wrinkly pastries that kinda look like tonsils. You may also see purulent exudates on those big red tonsils, which is represented by the frosting drizzled on the pastries and dripping onto the oven. And while you're back there, be sure to look for palatal petechiae. See the red splatter stains in the oven? And a red inflamed uvula, represented by the round red light in the oven. Next up should be your skin exam, where you'll be looking for a scarlatiniform rash, so named because it resembles the rash of scarlet fever, and is represented by the red dot stains all over this chef's apron. If present, you'll see and feel a diffuse red sandpaper-like rash that classically starts in the groin and axilla and spreads to the trunk and extremities. The rash will then undergo desquamation, which is depicted by the white oven mitt that our messy chef has dropped. For more details on scarlet fever and some of the other dermatologic manifestations of group A strep infections, check out our sketch dedicated to it in the dermatology unit. Alright, so you're pretty sure your patient has strep pharyngitis, but how do you confirm? The diagnosis relies on a positive microbiologic test, either a rapid antigen detection test or a throat culture. But who do we test? Clinical scoring systems have been created to rule out GAS infection in adults, including the center criteria. Adults who meet all the center criteria can even receive empiric antibiotic treatment without testing. However, these scoring systems are not sensitive or specific enough to rule out testing in children and adolescents, so don't use them when evaluating your pediatric patients. Instead, for kids older than 3, look for acute tonsillopharyngitis on physical exam, specifically in the absence of symptoms of a viral infection. For kids less than 3 with prolonged atypical symptoms, test them if they have close contacts at home or school with group A strep infection. Alright, back to the tests to confirm strep pharyngitis. The first is the Rapid Antigen Detection Test, or RADT. To collect the specimen for the RADT, grab 2 swabs and vigorously swab both tonsils and the posterior oropharynx. You'll see that our chef is holding tongs that look like 2 Q-tips to help you remember this. Also, make sure to avoid touching the tongue or buccal mucosa, as this could compromise the test, and is represented by the Do Not Touch sign on the oven door. If the RADT is positive, then pat yourself on the back and throw the second swab away. If the RADT is negative, the second swab should be sent for throat culture, hence the Petri serving dish our chef is holding, because the sensitivity of the RADT is only 70 to 90%, so a negative test does not rule out GAS infection. Throat culture, on the other hand, has a sensitivity of 90 to 95% and is considered the standard for diagnosis of strep pharyngitis. Throat cultures should be incubated for 48 hours and monitored for growth of GAS. When you begin to suspect a diagnosis of strep pharyngitis, be sure to keep in mind other causes of pharyngitis, specifically viral causes, including mononucleosis, Coxsackie-A viruses, adenovirus, and herpes simplex. Check out the differential diagnosis menu for a more in-depth look. Okay, you've got the diagnosis, so let's move right along to the plan. First off, kids with all types of pharyngitis would benefit from fever and pain relief with NSAIDs or acetaminophen, shown here with our recurring NSAID fire extinguisher. Next, kids with symptomatic pharyngitis and a positive rapid antigen test or culture should also be started on antibiotics. Remember how we mentioned that there has been no documented resistance to penicillin among GAS isolates? Thus, penicillins are the antibiotic class of choice, as they are cheap, safe, and narrow spectrum, and are represented here by the purple pencil behind the chef's ear. In kids, amoxicillin is often preferred because it tastes better. I mean, I just look at those delicious flavors in the amoxicillin ammo box for the frosting gun. The duration of treatment for streptococcal pharyngitis is 10 days, represented by 10 grubby frosting-covered fingers. If patients are non-adherent to the oral regimen, penicillin G benzathine can be given intramuscularly as a one-time dose instead. In other words, you can be stabbed by a purple penicillin pencil. While empiric treatment is typically not recommended, antibiotics can be started if your patient very clearly demonstrates features of strep pharyngitis, but only while further testing is being completed. If these tests come back negative, then the antibiotics should be discontinued. The prognosis for streptococcal pharyngitis is quite good, with a resolution of fever and symptoms typically within 1 to 3 days of starting antibiotics, which is shown here with a calendar that has January 1st and 2nd crossed out and a happy face on January 3rd. Not only do antibiotics reduce duration and severity of symptoms, but antibiotics also reduce the spread of infection. In addition, another major goal of treatment is to reduce the risk of suppurative and non-suppurative complications of streptococcal pharyngitis. Let's review those complications now. First on the list of suppurative complications is peritonsillar abscess, or PTA. The classic presentation of PTA is unilateral throat pain, trismus, a muffled voice, and uvular deviation. This is represented by the platter in the case with two cinnamon buns that kind of look like an oropharynx, and the big red abscess bun pressed up against one of the cinnamon buns. Refer to our dedicated sketch on PTA and retropharyngeal abscess for more details. Next up on the list for suppurative complications is otitis media, which occurs via direct extension of GAS from the pharynx to the middle ear via the eustachian tube. You'll see this depicted by our chef, who is plugging his ears against the little brat's shouting. Check out our otitis media sketch for a refresher. The next suppurative complication is sinusitis, which commonly presents with headache, persistent coryza, and postnasal drip. The affected sinuses will be tender to palpation. Finally, GAS can cause necrotizing fasciitis following a break in the skin, characterized by unexplained rapidly increasing pain, erythema, crepitus, and bulli, and is represented here by the burnt necrotic gingerbread man in wax paper fascia. Let's move on now to the non-suppurative complications of streptococcal pharyngitis. The most important non-suppurative complication is acute rheumatic fever, which typically occurs 2 to 3 weeks after a case of strep pharyngitis. The prevention of ARF is actually one of the main reasons we treat streptococcal pharyngitis. You can see ARF depicted here by the flaming rhubarb pie that is falling off the tray. Check out our dedicated ARF sketch for a more in-depth look. The next non-suppurative complication is scarlet fever, a delayed type skin reaction to an exotoxin produced by GAS, which typically presents between 2 and 5 days after infection. Look for circummoral pallor, strawberry tongue, and a sandpaper-like rash that starts in the groin and armpits and expands to the trunk and extremities, and eventually desquamates. This is depicted by the burning gingerbread man falling off the tray. If you look closely, you can see he has a white mouth and is covered in coarse red sugar crystals that are falling off. Be sure to look at our staph and strep skin infection sketch for more on scarlet fever. Next up, we have toxic shock syndrome, which is a rare complication caused by the release of toxins from staph bacteria. You can see it represented by the toxic symbol stove burner, and the outlet with a lightning bolt coming from it. Another complication that can occur following strep pharyngitis is reactive arthritis, which typically appears 7 to 10 days after a strep pharyngitis infection and may involve one or more joints. You'll see our startled chef happens to have his wrist, elbows, and knees wrapped to help show this. And finally, the last non-suppurative complication of streptococcal pharyngitis is glomerulonephritis, which is depicted by the knotted red glomerulus-looking telephone cord. The presentation of post-streptococcal glomerulonephritis varies widely from asymptomatic microscopic hematuria to nephritic syndrome, with red and brown urine, proteinuria, edema, hypertension, and acute renal failure, and typically presents 1 to 2 weeks after a strep pharyngitis infection. If you take another look at our calendar, you can see a date circled at the end of the 2nd week. All right, let's wrap up this sketch with a brief review of what we've learned. Strep pharyngitis most commonly occurs in school-aged children and presents with a sore throat, fever, and headache, which may be accompanied by abdominal pain, nausea, vomiting, and poor oral intake. What you won't see are viral symptoms. Don't test these kids for strep pharyngitis. In contrast, children under 3 will often have an atypical presentation with fever and clear nasal discharge. So be sure to ask about close contacts with GAS infection. During the exam, you will likely see tender anterior cervical lymphadenopathy, enlarged erythematous tonsils with purulent exudates, and palatal petechiae. Lastly, you might see a scarlatiniform rash that eventually desquamates. A diagnosis of strep pharyngitis can be confirmed with a rapid antigen detection test, which, if negative, should be followed up with a throat culture. Kids with symptomatic pharyngitis and a positive rapid antigen test or culture should be treated with penicillin or amoxicillin, which is more palatable for kids. Common suppurative complications include peritonsillar abscess, otitis media, and sinusitis. Non-suppurative complications, which can occur days to weeks after infection, include acute rheumatic fever, scarlet fever, toxic shock syndrome, reactive arthritis, and post-strep glomerulonephritis. Well, Now that all these fires and meddling kids have been taken care of, I think it's time we reward ourselves with some cinnamon rolls. Oh, hot, 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 oh, stop the recording. Oh.